When you hear the phrase birth control, the image that usually pops into your head belongs to a very specific stage of life.
Right, you probably picture someone in their 20s or 30s.
Yeah,
Yeah.
exactly. You think about like setting an alarm on your phone so you don't forget to take the daily pill, or maybe navigating clinic visits before you go backpacking across the world.
Yeah, the whole cultural narrative we've built around contraception, it really frames it almost exclusively as this young person's game.
It really does. But the clinical data in the sources we're looking at today paints a very different picture. If you're navigating contraception in your 40s and 50s, the stakes are still remarkably high.
They are. Because the focus of reproductive health messaging is so skewed toward those early years, by the time people reach their late 40s, they often just assume the need for, like, rigorous contraception naturally fades away.
Because fertility declines, right?
Right. Fertility absolutely does decline with age due to biological changes, but, and this is a shocking fact from the guidelines, the unplanned pregnancy rate in women over 40 can actually reach up to 75%.
75%? That is wildly high.
I know, it's huge. And the mechanism behind that figure is this mix of biology and psychology.
How so?
Well, psychologically, many women assume that infrequent periods mean they aren't fertile anymore, so they just stop using protection.
Which makes sense logically, I guess.
It does, but biologically, the perimenopausal period is characterized by really unpredictable ovulation. The ovaries are running out of viable follicles, so they kind of sputter.
Sputter, like a car running out of gas.
Yeah, exactly. You might not release an egg for several months, and then completely out of the blue, you just randomly release one. And if unprotected sex coincides with that random release, you get an unplanned pregnancy.
Wow. So this high risk of pregnancy means doctors often advise women to stay on their contraception way longer than they probably anticipate.
Much longer, yes.
And this brings us to the core mystery we are exploring in this deep dive. As you approach perimenopause and menopause, using highly effective hormonal contraceptives like the Mirena coil or the mini pill, it creates this really confusing biological overlap.
It's a massive overlap.
Right. So we are going to unpack how these specific methods actively complicate and honestly often completely mask the diagnosis of menopause and, what you can do to figure out what's really going on in your body. Okay, let's unpack this.
The start, to really understand this diagnostic complication, we have to establish the baseline. We need to look at how menopause is diagnosed without any hormonal interference.
Because there's a big mismatch in definitions here, isn't there?
A huge mismatch. In the doctor's office, patients usually define menopause by the symptoms they're feeling, right? The hot flushes, the night sweats, sleep changes.
The stuff that actually disrupts your day.
Exactly. But clinicians, they define menopause as a very specific biological event, the permanent cessation of ovulation.
So it's basically a clinical diagnosis that relies entirely on looking backward.
Yes, it's retrospective. The medical guidelines define menopause as 12 months after a woman's final menstrual period.
Or 24 months if she happens to be under 50, right?
That's right. You essentially have to just wait out the clock to make sure the biological signaling has definitively stopped.
And that biological signaling stopping that's driven by the ovarian follicles depleting, right?
As the follicles run out, the ovaries stop producing the estrogen and progesterone that usually thicken and shed the uterine lining. When the hormones drop permanently, the bleeding stops permanently.
So in a natural, unmedicated state, just tracking that absence of bleeding is your main diagnostic tool.
Exactly. It's straightforward.
But here comes the massive complication, the mask. The moment you add highly effective hormonal contraception to the equation, that tool is gone.
Totally gone.
Because if you're taking the progestogen-only pill, the mini pill, or the implant, or the Mirena coil, your natural bleeding patterns are already being fundamentally altered by the medication.
Yeah, the sources note that these methods frequently cause erratic bleeding or very light bleeding, or they induce amenorrhea, which is when your periods stop altogether.
Which, a lot of people view as a massive benefit.
Oh, absolutely. But diagnostically, it completely removes your primary metric for tracking menopause.
It's kind of like, think of it like wearing a pair of high-end noise-canceling headphones during a severe thunderstorm.
Oh, I like that analogy.
Right, like the storm is still happening all around you, the lightning is flashing, the wind is howling, and that represents the menopausal transition happening inside your body.
Right, the biological aging of the ovaries is still continuing at its normal pace.
Exactly. But because you have those headphones on, the medication is muting the thunder. You just can't hear the definitive signal of your natural period stopping.
That's a great way to put it. The guidelines are very clear on this. Hormonal contraceptives do not change the underlying course, timing, or duration of menopause.
Mm.
They just mask the outward signs.
So hearing that, a very logical question that you might want to ask your doctor is, why not just take off the headphones?
Right, just stop taking the pill or remove the coil for a few months to see if your natural periods come back.
Yeah, like why not just do that?
Well, the guidelines actually strongly advise against this approach
Really? Why?
because taking off the headphones to check for thunder exposes you directly to that erratic ovulation phase we talked about earlier.
Oh, right, the sputtering ovaries.
Exactly. During perimenopause, your hormone levels are fluctuating wildly on a daily basis. The ovaries might seem totally dormant for months and then suddenly release an egg.
So removing the contraceptive protection just to check your menopausal status is exactly what leads to that massive rate of unintended pregnancies.
Yes, it's a huge diagnostic trap. You can't rely on tracking periods because the hormones mask them, and the medical consensus says don't stop the hormones because the pregnancy risk is too high.
Which naturally leads pretty much everyone to ask their doctor for a blood test. I mean, you'd assume a simple hormone panel would just give you a definitive answer, right?
You would assume that, yeah. The documents actually refer to this as a really common clinical pitfall. Women beg their doctors for a hormone test to get some clarity, only to be told the test is useless.
Right, the FSH problem. So to understand this, we need to quickly look at the brain-ovary feedback loop.
Let's do it.
In a natural postmenopausal state, as the ovaries shut down, estrogen levels, specifically estradiol, drops significantly.
Right. And the brain senses this low estrogen and tries to kickstart the ovaries by pumping out higher levels of follicle-stimulating hormone, or FSH.
Along with luteinizing hormone, right?
Yes. The pituitary gland is basically acting like a thermostat. When it senses the heat the estrogen is too low, it turns on the furnace by releasing FSH.
But in menopause, the ovaries can't respond to the FSH anymore.
Exactly. So the brain just keeps pumping it out. That's why a natural postmenopausal blood profile shows low estradiol and persistently elevated FSH.
But, and here's the huge catch, the clinical guidelines explicitly state that if a woman is taking combined hormonal contraception, an FSH blood test is completely invalid.
Entirely useless.
And combined contraception means methods with both estrogen and progestogen, like the traditional pill or the patch, right?
Yes. And the reason it's useless is because the exogenous hormones from the combined pill flood your system. Your brain senses these artificial hormones, thinks the body has plenty of estrogen, and suppresses its natural production of FSH.
Ah, so the medication just overrides your body's natural signaling system entirely.
What's fascinating here is the illusion of certainty it creates. If a clinician draws blood under these circumstances, they're merely measuring the artificial suppression caused by the daily pill.
Not the actual underlying function of the ovaries.
Right, and a suppressed FSH reading could trick someone into thinking their body is still highly fertile and nowhere near menopause.
Or the opposite, right? Like testing an under 50 woman's FSH levels while she's menstruating or on combined hormones can give false reassurance.
Yes. Because hormone levels fluctuate so dramatically, an FSH level might read as postmenopausal on a Tuesday, and then by Friday, a sudden estrogen spike makes her highly fertile again.
Wow. So basing a decision to abandon contraception on a single suppressed blood test is incredibly risky.
It really is. Now, the Faculty of Sexual and Reproductive Healthcare, the FSRH, their guidelines do carve out a specific exception.
But it requires moving away from combined hormones entirely, right?
Yes. For individuals using progestogen-only methods, the diagnostic window actually opens up slightly.
Okay, so let's get into this over 50 rule. The sources outline this very specific rule for progestogen-only contraception, so that's the mini pill, the arm implant, or the DMPA injection.
Right. If you are over 50 years old and you currently have no periods, you fall into this category.
And because progestogen alone doesn't suppress the brain's FSH production in that profound way the systemic estrogen in a combined pill does, an FSH blood test can actually be useful here.
Exactly. The progestogen allows your body's natural FSH levels to actually show up on the blood panel.
And there's a magic number for this test, isn't there?
There is. The FSRH establishes a specific threshold, a single serum FSH measurement, greater than 30 IUL.
30 IUL, and hitting that indicates a significant degree of ovarian insufficiency.
Yes, it gives you a strong, scientifically backed signal that the biological transition is well underway.
Wait, so if the test comes back over 30, does that mean she can just throw out her mini pills that exact same day?
No, absolutely not.
Oh, really? Why not?
There's a crucial safety buffer. The medical directive requires that even with an FSH measurement over 30, you have to continue using your contraceptive method for one more full year.
A whole year, just to be safe.
Yeah, that one-year buffer addresses the stubborn nature of perimenopausal biology. An elevated FSH confirms the ovaries are failing, sure, but it does not guarantee immediate permanent sterility.
Because of that lingering risk of a late-stage spontaneous ovulation we talked about.
Exactly. The 12-month continuation is basically a mandatory safety net to make sure ovarian function has completely stopped.
Okay, that makes sense. And the guidelines also mention a really specific logistical quirk regarding the DMPA injection, right?
Oh yes, the injection is unique. Unlike the localized progestogen of the Mirena or the low dose of the mini pill, the systemic concentration of the injection can actually slightly suppress FSH levels.
So how do you get an accurate reading then?
You have to draw the blood test right before the next injection is due.
At the trough level.
Right. At the trough level, the medication's concentration in your bloodstream is at its absolute lowest, which minimizes that suppressive interference.
So you draw the blood to get the clearest picture of the natural hormones and then immediately get the next shot to stay protected.
You got it.
Okay. But honestly, listening to all this navigating trough levels, one-year safety buffers, masking effects, it sounds exhausting.
It is a lot of clinical math.
Yeah, so you might be listening to this and wondering, why would anyone in their late 40s or 50s choose to stay on hormonal contraception when it makes diagnosing menopause so incredibly complicated?
It's a very fair question.
Like, why not just switch to non-hormonal barrier methods like condoms or a copper IUD and let nature take its course so you can actually see your body's signals?
Well, and for some people, transitioning to non-hormonal methods is absolutely the right path. But the sources emphasize a major reframing here. In these later reproductive years, hormonal contraception isn't just about preventing pregnancy anymore.
Right, it transitions into this highly potent management tool for all the physical disruptions of perimenopause. They basically do double duty.
They really do. For instance, combined oral contraceptives, the exact same pills that render the FSH blood tests useless, they're actually the only contraceptive option with proven efficacy for improving vasomotor symptoms.
Vasomotor symptoms meaning the hot flushes and night sweats.
Exactly. The systemic estrogen in the combined pill smooths out those wild daily hormonal fluctuations that trigger the flushes.
Oh, wow. And beyond that, the combined methods offer massive protection for bone health, right?
Yes. As natural estrogen plummets during menopause, you lose bone mineral density, increasing the risk of osteoporosis. But the estrogen from combined contraceptives actively inhibits the cells that break down bone.
So it's protecting your structural density during a really critical window.
Exactly. And then you have the Mirena coil, or the levonorgestrel intrauterine system, which has a totally different but equally vital benefit.
Yeah, the guidelines highlight it as incredibly effective for managing heavy menstrual bleeding, or HMB, which is super common over 40.
Super common. During perimenopause, you get a lot of cycles where you don't ovulate. And without ovulation, your body doesn't produce the progesterone needed to balance the estrogen that's building up the uterine lining.
So that unopposed estrogen just causes the lining to grow excessively thick.
Right, resulting in periods that are way heavier, longer, and honestly more painful than they used to be.
But the Mirena delivers local progestogen directly to the source, thinning that lining and drastically reducing the bleeding.
Often eliminating it completely.
Which leads to this ultimate crossover application that I found so fascinating in the sources. The Mirena coil can actually be integrated directly into hormone replacement therapy, or HRT protocol. Yes, this is such a crucial point. When patients use HRT to manage severe menopausal symptoms, they're usually prescribed systemic estrogen via a patch or a gel.
But adding continuous estrogen stimulates the lining of the womb, which increases the risk of endometrial hyperplasia and cancer.
Exactly. So medically, you are required to pair that estrogen with a progestogen to protect the womb. And the guidelines confirm the Mirena coil can serve as that precise progestogen component.
It's just incredible synergy. You get systemic estrogen for the hot flushes and mood changes, while the intrauterine device provides targeted protection against endometrial thickening.
And it maintains highly effective contraceptive coverage all at the same time. If we connect this to the bigger picture, staying on contraception isn't just about birth control, it's about preserving your quality of life.
There is one specific caveat for this crossover use, though, right? Yes, an important one. The sources note that if the Mirena is being used specifically as the progestogen component of HRT, it must be replaced every 5 years.
Even if that specific model is licensed for longer as a standard contraceptive.
Right. because the hormone levels have to remain high enough to ensure adequate protection against the continuous influx of the HRT estrogen.
Got it. Okay, so all of this complex overlap between contraception and menopause, does it ever just end?
It does. The sources do provide a definitive endpoint.
And the guidelines establish a clear clinical cutoff at age 55.
Yes, 55 is the magic number. At this age, the natural loss of fertility can be safely assumed for the vast majority of the population.
Even if someone is still experiencing, like, sporadic bleeding.
Even then, spontaneous conception after 55 is considered exceptionally rare. So generally, contraception can be safely stopped at this age without needing any more blood tests.
But there is a safety directive about stopping certain methods earlier, around 50, right?
Yes, the sources strongly recommend that if you're using combined hormonal contraception or the DMPA injection, you should stop those specific medications at age 50.
Because the risk factors for cardiovascular events and blood clots increase significantly with age.
Exactly. So the guidelines advise transitioning to safer, progestogen-only methods or non-hormonal barrier methods for those final 5 years until you hit 55.
Managing all these risks while trying to maintain symptom relief, it really requires careful navigation with a doctor. The physiological changes are inevitable, but how you experience them can be heavily modified.
It's all about weighing the clinical benefits of heavy bleeding management against the diagnostic mystery created by masked menopause.
Right. Deciding whether to keep those noise-canceling headphones on is a deeply personal choice. It just depends on which symptoms impact your daily life the most.
Absolutely. Your doctor is there to help you figure out what makes sense for your specific situation.
So, as we wrap up this deep dive into the medical guidelines, there's a broader implication here worth considering. We are talking about an era of medical technology where hormone management is so effective that the physical milestones of menopause can essentially be erased.
It's true. By using these methods, you might literally never experience a definitive final period.
You might never feel a hot flush or track the erratic bleeding that historically signaled this massive life transition. And, if medical interventions prevent our bodies from delivering those definitive physical signals that a reproductive era has ended, it fundamentally alters how we perceive our own aging process.
That's a really profound way to look at it.
If the internal biological storm occurs exactly as programmed, but the medication ensures you never actually hear the thunder, how do you mark that transition for yourself? It's a fascinating intersection of modern medicine and personal identity, and definitely something to reflect on as you navigate the options available to you.